Good morning, everyone, and thank you for joining us. Our speaker today is Dr. Katherine Freeman Costin. Dr. Freeman is the director of the Biostatistics Collaborative Core within the FAU Division of Research and professor in the Charles E. Schmidt College of Medicine. She is an expert in the design and statistical analysis of multi-center randomized clinical trials, observational studies, and a wide array of other statistical methods. Prior to coming to FAU, Dr. Freeman was on the faculty of the Albert Einstein College of Medicine for over 30 years. She has been the principal investigator, co-investigator, or core director on many NIH and foundation-funded grants involving health disparities, public health promotion, intravenous drug use in HIV, and most recently, pregnant women with opioid use disorder. As a biostatistician, she has collaborated on numerous grant applications and has over 130 peer-reviewed publications to her credit. She has taught biostatistics, epidemiology, critical review of the literature, clinical trials methodology, and meta-analysis to faculty from varied disciplines. Dr. Freeman has also served as a member of several institutional review boards and chair of several NIH and industry-sponsored data safety monitoring boards. We are very happy to welcome Dr. Freeman today and thank her for presenting this very important and timely topic.
Okay, when I give a talk, I usually like to give a roadmap of where we're going. And what we're trying to do here is to understand the scientific and procedural components of clinical trial protocols. So basically it's a recipe. And we're going to think about alternative clinical trial designs because some are more efficient than others, more cost-effective, and in the era of epidemics, more timely. We want to get the results out as quickly as possible and implemented. We're going to consider statistical issues in the design, analysis, and reporting of clinical trials. And we start with a definition of a clinical trial. And that's really a way of comparing groups that involve human subjects. Typically we're following at least one group prospectively, and the outcomes of these clinical trials would involve health, medical, biological related concerns. We're going to talk about the purpose of the study. Most important thing in research, if people have heard me before, is the research question. We're going to talk about the interventions, treatments, and how they're administered, definitions of the patient sample, study configuration, and methods of assigning patients to different treatment arms. Masking, which is a way of avoiding bias in terms of assigning people to different treatments and evaluating their comorbidities and outcomes, and behavioral assessments. A little bit about number of centers, whether it's a simple trial involving one center or more complex. Also the time periods for conducting this study. There are the administrative, the grant-supported time periods, as well as the time period with the perspective of the participant, the patient who enrolls in a trial. What's going to happen to them? Issues related to the withdrawal from the protocol, data management, a little bit on biostatistics considerations, how we're going to analyze them, why are certain things so important. Forms design, compliance, adherence to the study protocol. People are very heterogeneous. As we see in the COVID epidemic, people want to do what they want to do, and that stands true for participating in a clinical trial. How missing information might adulterate, the clinical trial and the analysis and contribute to bias. And then with a little bit about data and safety monitoring boards, of which I'm on several, and how to document the results so that you can communicate not only to the peers and your audience in a journal or a presentation, but to have a standardized approach to continue on to what's called meta-analyses and systematic reviews. Okay, so let's start with the research question. There are a variety of approaches: therapeutic, prophylactic, diagnostic. But let me give you some examples from these various epidemics. Therapeutic. Well, for HIV, we had and are continuing to provide treatment to patients involved in randomized trials. One of the earliest, if not the earliest, NIAID therapeutic trial compared AZT with placebo. What the primary outcome was time to death. We wanted to prolong life as quickly as possible. From that era, a lot of outcome measures concerning quality of life evolved, and ways of looking at the data in terms of distributing the patient population to areas outside of the major medical centers, which usually are the ones conducting national clinical trials. Okay, prophylaxis, prevention. In the obesity era, we're trying to promote prevention of obesity by imposing educational modalities to train the children and also the family members to eat smart and have regular exercise. So that's an example of that. Diagnostic, here we are in the COVID epidemic, where hey, we have a variety of ways. I don't know if you remember way back when in March, that there are a variety of diagnostic tools to determine whether people had the infection or not. These various tools could be the intervention of a clinical trial that we can compare the sensitivity and specificity rates of the various tools. Other uses of clinical trials, again, involve systematic reviews and meta-analysis. To complicate clinical trials further, we might have certainly a primary and secondary outcome indicators that for HIV involve CD4, viral load, and time to death, and BMI, changing BMI for obesity. Opioid, it would be adherence to treatment, certainly depression. So we might have a primary and other secondary questions that we're looking at to address, and also subgroups. The AIDS epidemic really underscored the need to have a fair distribution of women involved in randomized clinical trials. I think the initial focus is on men. So that has been put into policy if you're applying for an NIH grant. I want to give a nice set of graphs for how to kind of display or communicate the various outcomes that can be derived that you specify beforehand in your protocol that could be experienced by different participants in the study. Okay, treatment and administration, certainly drug trials such as HIV involve choosing different treatments, what's more optimal, literature reviews, et cetera, regimens, how many times a day, and formulation. If you're having a placebo-controlled trial, you want to certainly, level the playing field by making sure that the taste, smell, capsule size are consistent between the placebo and the active treatment. You have to ask the question, are concomitant treatments allowed? For the opioid epidemic, we have behavioral interventions, but people involved in clinical trials in this area might be on different modes of treatment for substance use, such as methadone, buprenorphine, and how do we consider that as part of the design of the study? Okay, the doses could be fixed or tailored to events. In AIDS clinical trials, we had people being followed over time, and perhaps different dose regimens might change according to whether they had a particular type of opportunistic infection. Now, we have to, as part of the protocol, we have to define the patient sample. And we, in statistics, not only is the research question important, but the what's also important is relative to what. So we have, we want to define our control group or groups. We could certainly have more than one. We can use a historical control, like in the obesity epidemic. There are plenty of cohorts of, diet and exercise modalities whereby data are captured that we don't have to reinvent the wheel to have a concurrent control, but we could also more optimally have a concurrent control, which would control for environmental factors, disruptions in society like the COVID, epidemic. And we could also have randomized controls. Randomization is a method of assigning participants to different treatment groups that avoids bias, and we'll get to that a little later. We want to define inclusion-exclusion criteria, and we'll go through that shortly, and looking for sources of bias, whether they're in recruiting participants into the study. People have heard about samples of convenience, or putting an ad up in the university. Well, you're going to get more students in that, and your results may not be generalizable to the entire population. And certainly looking at subgroups that may not complete, reporting forms. All right, in terms of highly restrictive selection criteria, there's certain advantages. You're deriving a very homogeneous population or sample to extrapolate to a population. And the advantage is that because of this lack of variability, you're going to have greater power or the ability to detect the same difference if there is one. Or alternatively, you would need fewer subjects to, to recruit, which is an advantage in terms of money and time. The disadvantages are that there'll be increased time to accrue subjects. The inferences are limited to people who mirror those in the sample. And because you have a laundry list of exclusion criteria, by chance, one of those criteria may invalidate enrollment into the study. So you may be excluding patients incorrectly. Okay, well, what if you broaden the criteria for entry and you have minimally restrictive selection criteria? Well, the advantage is that it's certainly easier and faster to recruit. Generalization isn't compromised. The disadvantage is that often in a major research institution, you have investigators competing for the same patients. And then perhaps possibly the RRB steps in and says, okay, we'll recruit for this first or this later, or perhaps we can tailor the entry criteria so that we'll have mutually exclusive recruitment groups. okay? And with greater heterogeneity among people, their baseline characteristics, for the same difference, you'll have lower power or less ability to detect statistically significant differences. And alternative to that, you would need a much greater sample size. Okay, let's talk about different study designs. All right, we mentioned a little about the using a historical control, which means that you would have a single arm, and this is often used, or this has been used from my experience, in early stent trials where it might have been thought that following a prospective control group it might be, somewhat unethical. And they were looking for feasibility, and the FDA, branch really didn't necessarily require a concurrent control group. Okay, then the type of design that you would see more often would be a parallel arm design, which I mentioned, the AZT versus placebo in HIV. But we certainly have other examples from the opioid epidemic, where one group of children is receiving the intervention, which is basically a handouts with regard to diet and exercise. And the alternative arm would be not only receiving that kind of enhanced treatment as usual, but also family intervention. How to motivate the family to keep the child on track, how to change their behaviors in terms of, dietary issues. Then we have a kind of a special style of a parallel arm design, which is called a factorial design. And for example, in the opioid epidemic, if we were to train counselors, clinicians, with regard to motivational interviewing and or shared decision-making, we could conceivably make this into a 2x2 factorial design by having one treatment, A, shared decision-making, yes or no, and the other treatment, B, which would be motivational interviewing, and then we'd have 4 groups. And those 4 groups are represented by AB, so there certain clinicians are receiving both, B only, not A, and A only and not B. And then either what I put in there as a phi would be either, a placebo, or in a behavioral trial is really treatment as usual, or enhanced treatment as usual. Okay. Now, the advantage of conducting a factorial design is that you can assess an interaction effect, meaning that is it expected that shared decision-making along with motivational interviewing really increases the amount of compliance or adherence or engagement of patients or participants much, much longer and much more than those who were receiving treatment from clinicians involving either of the 2 interventions, okay? Or conversely, can it have an antagonistic effect? Okay. Other studies, designs that really conceived in the era of early HIV trials involve what's called parallel tracks, where the physician and the patient decide what treatment the patient will get. So it's really kind of empowering the patient, but more than that, it was really a vehicle for getting perhaps potentially potent drugs out to communities other than those encompassed by major medical centers where they're conducting, NIH-funded trials. So minimally, those are really observational studies, and patients are being treated with a variety of regimens and whatever, and they're more hypothesis generating studies. Okay. Another type of design, which you may have heard of, is called a crossover design, whereby during period 1, patients are randomized to treatment A or B, or you could have C or D, or how many other treatment interventions. And then if it's a drug trial, or then you have a period whereby the drug is washed out of the patient's system. And then in period 2, those who originally received treatment A are switched to treatment B, and those from period 1 who originally got treatment B are then switched to treatment A. Now, the advantage of this trial design is that because each patient is used as his or her own control, you're reducing the amount of variability or noise in the study. And when you reduce variability, you're increasing the power of the study. And also, alternatively, you may need fewer patients to participate, which is a good thing. Okay, now the restrictions on this type of study design involve that you can only do this with an underlying chronic disease that remains relatively constant. So there may be certain, now that, HIV has become, a chronic disease, you may be able to use certain of these crossover designs. These are often used in hypertension. You want to make sure that the disease doesn't go away, and I don't, mean to be flippant about that. It's just that if the disease is cured, then patients in participants who enter period 1, if they're cured thereafter, they can't enter period 2. So, so you can have a dichotomous outcome, success or failure, or cured or not cured. Okay, there can't be any carryover effects. So you want a sufficiently long washout period. Certainly, if patients are on treatments prior to period 1, you want what's called a run-in period, or a pre-washout period, so that any influences of concomitant medications can be, quote unquote, washed out. So you want the characteristics of patients when they start period 1 to be somewhat the same as when they start period 2. Okay, another type of more complicated randomized trial is called a clustered randomized trial, whereby clusters of groups are randomized instead of individual subjects. An HIV trial that I've been involved with on the Data and Safety Monitoring Board, clusters are being assigned to different treatment groups according to whether the cluster is within a physician's panel. So it's considered that if patients within a physician's panel are more likely to respond similarly than patients in another physician's panel, then one would perhaps want to randomize the clusters. In the opioid epidemic, my colleague Heather Howard and I are responding to NIH comments with regard to a clustered randomized trial whereby peer support specialists are randomized to either get a shared decision-making intervention versus not. And within the individual peer support specialists, they also have panels of patients. So those patients, those participants are also, more likely to respond similarly if they're connected to providers of care that receive particular training than others, or there's, depending upon their style of care that's being given out by the peer support specialists. Okay, so, so this brings up the point of contamination. In the HIV trial, the earliest one with AZT versus placebo, the community stakeholders who were participating in the trial were activists, and it's interesting because the evolution of patient involvement in clinical trials has really evolved from these early years in HIV clinical trials. What happened at that time is that people were desperate, as they are in any, epidemic and pandemic. They want to be safe. They want their disease to be cured. But what happened early on was that the placebo pills and the active AZT pills were being tested in labs, and participants who were assigned at random to the placebo group were either dropping out of study or sharing their treatment with those who were assigned AZT and who were getting AZT. And that concept is called contamination. And we're seeing that that certainly could be a possibility with this trial involving the peer support specialists, and we're doing our best to try to avoid contamination. Okay. Another study design involves a stepped wedge study design. Again, another HIV trial that I'm involved with is designed as such, whereby you have physicians' practices. This is a study of patients with HIV who have received a variety of drugs throughout their years, and whether it was the drug or the disease itself that has increased the risk of cardiovascular disease. This is this trial involves an educational intervention. Now, because of the homogeneity of the patient population within each provider, and with regard to maybe, regional characteristics or the type of care that the provider provides, it was thought to do what's called a stepped wedge study. So the horizontal axis indicates time. So as time goes on, you have different groups being exposed to different interventions. So the yellow represents treatment as usual. So after, say, 1 month of those patients getting this, their treatment as usual, then one of these clusters is chosen at random and assigned to the intervention group, which is denoted as blue. And then as time goes on, one more is chosen at random and assigned to the intervention group. And this is done because not only do you have physician panels that are more homogeneous, but you can have, classrooms, you can have different regional areas that the government assigns different interventions. In fact, we all can consider ourselves part of a stepped wedge study design, because think about the intervention as opening the economy. So if different regions are exposed to opening the economy, and over time, the entire economy will be open, and then we're going to see if there's a relationship, certainly between the incidence of COVID infection and deaths and, opening the economy. And we're certainly also able to look at, with other clinical trials, to see whether there are differences between the intervention and controls at particular points in time. Okay, there are a variety of statistical measures in step wedge study designs, but typically you would either analyze data at each point in time, which is not necessarily recommended, or use a mixed effect hierarchical model, which is quite complex because you have not only repeated time points, but also repeated measures in terms of patients being exposed to both interventions. Okay. Okay, so here we have an example from the COVID arena, pandemic, and this is all simulated data. But what's happening now is that patients get diagnosed, as having COVID or not, being exposed, infected, and then they might, if symptoms are severe enough, they go to the hospital. And each of these little boxes refers to either treatment or control. The horizontal axis is days since randomization. So we're kind of setting up a fictitious clinical trial, which may occur in the future, whereby we're looking at points in time, chronologic points in time, as opposed to the patient's perspective of their chronology. So this is on day 1, March 20th. What proportion of patients in the hospital who have received treatment are either have been discharged alive, not ventilated, or have died. So as time goes on, these become more meaningful. And what you're doing is actually dichotomizing each of these outcomes. And then you're displaying the proportion at the various points in time, in different colors. And you're looking at each of the graphs, comparing them with regard to areas that reflect the different outcomes. And you could see, for example, that those who died appear to be more in the greater in the control group than in the treatment group. And in the treatment group, conversely, perhaps those who are discharged alive, are greater. The area under the greater above the curve is greater among those discharged alive in the treatment group as opposed to the control group. But you have a way of communicating to the lay audience and even, epidemiologists and biostatisticians, the crux of what's going on. This is not a statistical analysis, but it's a way of communicating finding. Okay, well, how do we assign treatments or interventions to participants? Well, we start out with, in our protocol, we start out with a randomization ratio or treatment assignment ratio. And that ratio doesn't necessarily have to be 1-to-1. When the HIV AZT trials started, it was 1-to-1 because we didn't know any better. And the activists got very involved because they were stakeholders, and they decided that any active treatment would be more acceptable to certain communities with HIV infection. Subsequent trials involved various randomization ratios. I seem to remember one that was 4-to-3-to-1. In terms of the 4 and the 3 were those, who got, were proportional to those who got the active treatments, different doses, whatever. And the 1 was either a placebo or a standard treatment at the time. Okay, just tangentially related. There are trials that don't involve, ongoing randomization. And one type of trial is called an adaptive trial, whereby initially you flip a coin, and then these trials involve either success or failure dichotomous outcomes and short observation periods. So so what happens is that if the patient is originally assigned by flip of a coin to treatment A, they're followed, and then if they're a success, the next patient is assigned to treatment A until the point at which some patient in the future fails, at which point that next patient is assigned to treatment B. Okay, so this is an example of a trial, and I could see doing this with regard to, in COVID, with regard to the various types of diagnostic tools for COVID infection, and also serology. Another point about treatment assignment is in randomization is stratification. Often you'll see trials where patients are randomized, participants randomized to different groups in a completely randomized design. The problem with that is that you may end up with, and I've seen it, 20% more patients being assigned to one group as opposed to another. So in order to possibly control or minimize that disproportionate number in the various groups, and also to better balance the groups according to particular pre-specified characteristics, you impart what's called stratification. Often this is like identifying a factor such as, say, region, site, whether it was Johns Hopkins or my University of Miami, and say, okay, we're going to randomize within that site so that, at the end of the trial, when we pull all our data, we'll have a similar distribution according to site. So 50% of people will be in A versus B in Miami, and also in at Hopkins or other sites. Okay, in the HIV era, in the early HIV era, the focus was really on men enrolled in randomized clinical trials. However, it was noticed after a year or two or three that lesbians who are at greater risk of HIV infection because they socialize within a particular community were not participating in clinical trials. So NIH really mandated that there be clinical trials that would include women, and also that that they would be dealt with statistically appropriately in terms of the design by stratifying according to gender. Okay, randomization. Well, some people think that randomization is an equal probability of assignment, but no. It's a known probability of assignment. As I said before, there are trials that involve ratios of 4 to 3 to 1. Well, that's not a 1-to-1 randomization. It's not a 50% or a 0.5 probability of assignment. Please don't use an odd or even approach, even though it seems very easy, because of, say you're dealing with the odd or even day of the calendar month, and you're assigning people to one treatment on an even day and others on the odd day, because then you really know what the next patient is going to be assigned to. So that might introduce bias in terms of the either research associate or the investigator's knowledge about those patients' characteristics and whether he or she wants that patient to participate and in the trial at all, and also in a particular group. Okay, minimization is a form of randomization whereby you're continually adapting the sample who are randomized to particular treatment groups according to the characteristics of the patients who have already been randomized in that trial. So it's adapting. So if you find out that after 10 patients are randomized, group A has 20% females, then the next female that comes down the pike will have a greater probability of being assigned to that group. Not necessarily forced into that group, but being assigned to that group. Okay, a block randomization is a way of coming out of this randomization procedure with reasonably equal numbers of patients in the various treatment groups. And, you know, I stress that the blocking factor not be disclosed, so that if the blocking factor was, say, 8, then after, and you had 2 treatment groups, then after 8 patients are enrolled in the clinical trial, then exactly 4 will be assigned to treatment A and 4 assigned to treatment B. Okay, randomization can be done with a random number table or centrally, or, you know, a statistician has a program who could help you with that. The advantages: it forms the basis of statistical inference. It attempts to balance the groups. People are always worried about whether the groups will be balanced, but for very large sample sizes, and it avoids selection bias. Disadvantages are that certainly you can see whether the groups are balanced, but only for those factors that you've pre-specified. But randomization balances the groups for unknown characteristics, and unknown characteristics really can be distributed, you know, very disparately between or among the groups. And, you know, in a nutshell, randomization can go wrong. Okay, we talked about sample sizes and decisions and whatever. Treatment masking, or often, you know, sometimes called blinding, would mean that the people involved in the trial do not know what treatment groups the patient has been assigned to, patient or clinician has been assigned to. You know, double-blind trial refers to both the treating clinician and the participant patient not knowing, you know, what they're given. A single-blind trial involves either the patient, participant, or the clinician not knowing. An unblinded trial, which is really out of necessity part of behavioral trials, clinical trials, where you can't mask what treatment group the patient's in. You have to inform them in the informed consent form. Certainly in surgical trials, you may have a sham procedure, but even then, you know, somebody's going to know, you know, what incision they're imposing. And a triple-blind trial is where really nobody, and that third person that's blinded is really the evaluator. So you can provide data from different patients and clinicians, and they would not know what treatment the patient is receiving, but also who is going to be looking at the laboratory tests, which may, in the case of HIV infection, reveal the viral load, CD4 count. So that evaluator would be masked to treatment group. The other thing about masking is that how good a job did you do as an investigator in terms of masking? So what I would suggest is at the end of the study, you know, for, masked or blinded randomized clinical trials is ask them, ask the participants whether they thought they got the most optimal treatment, and ask them what treatment they think they received. Okay. There's really a push to translate results of clinical trials into practice, and that really is part of the procedure of designing a trial. Re-aim refers to reach, efficacy, evaluating the efficacy or effectiveness, adoption, implementation, and maintenance. So let's give some examples, of this. Reaching refers to how did you recruit patients? Who was eligible and who was really referred to the trial, and then who screened in, who met the eligibility, inclusion, exclusion criteria relative to the number actually enrolled. Enrolled means, they sign their informed consent and they're randomized to the different treatment groups. So we want to know the process of what's happening with this, and whether any biases enter into the study. With regard to the obesity trial, people were recruited from either, well child visits in medical centers, but then, you might get a group of people who are more informed about healthcare, who like their clinicians, maybe are more amenable to participate or practice the intervention that's provided. Oh, efficacy, effectiveness refers to, in the obesity trial, well, was there a change in standardized BMI scores? Was there a decrease in the incidence of metabolic syndrome as in the intervention group as compared to the control group? Okay, so that's where the specific aims come in. You're addressing those. Adoptions. There's, as I mentioned before, there's a team of people involved in the clinical trial. Those involve the clinicians who are administering treatment, as well as the participants. And before a clinical trial is implemented, all people from the team have to kind of buy into this notion of equipoise, which means that they really have to kind of believe that one of the treatments is not so superior than the other, that they're open to the fact that, yes, this trial should be done. And typically, this is asked of the clinicians, but it certainly should be asked of the participants also in a study, because they have the right to refuse. Okay, so the implementation, there are a variety of practices and interventions, educational sessions that are being given. I know in the opioid trial that we're working on at present, there are 4 different shared decision-making training sessions, each of 4 hours, once a week for 4 weeks. And in parallel, there's an attention-matched control set of sessions that will most likely involve gender, women's issues. We want to make sure that all the sessions are not only given appropriately and the scripts are standardized, but that we're reaching all the people involved in the study. And the last point is maintenance. Well, sponsors are giving a lot of money. Clinical trials are very costly, and they want to know that in the realm of the ivory tower of research, whether these interventions are sustainable in the real world. They can be maintained. So is there a cost-effective way, either by local support, funding, integrating these activities in standard of care to sustain these activities if an optimal method is found? Okay, I want to just briefly, we talked a bit before about numbers of centers and the complexity, and it passes down to the complexity of the statistical analysis. We talked before about, from the sponsor's perspective, the chronologic time frame, as well as from the patient's perspective. And those two perspectives need to be incorporated into a timeline because a lot of things are going on at once in a clinical trial. I want to touch briefly on the phases of testing of new drugs in the United States, especially how this relates to the COVID epidemic. The scientists are now working in their labs looking for promising drugs. They don't involve human subjects. And then they might use a few subjects and look at pharmacokinetic properties of the drug. And then they take healthy volunteers in doing a phase 1, or often called phase 1/phase 2 clinical study. Phase 1 and phase 2 involve seeing whether the drug of choice is safe. That is the most important thing when you're involving human subjects in these clinical trials. Now, in March, NIAID started a phase 1 clinical trial for a potentially notable vaccine for COVID. And they're enrolling 45 subjects between the ages of 18 and 55 years of age. And they have 3 different doses of this vaccine, and they want to find out the most optimal, dose to use in larger scale trials. What's notable here is that their, restriction criteria with regard to age. They are healthy, so that's another restriction criteria. What's happening in the COVID clinical trials is that people at higher risk are older than 55, and they have comorbidities. So how do we extrapolate from healthy volunteers to use for everyone? And it's a notable concern that people are considering as we speak. Okay, so I would kind of label that to be a phase 1/2 because we are looking at dose finding studies, but because time is of the essence, we're kind of doing both at one time. Phase 3 involves large-scale clinical trials in the AIDS epidemic. We had 3,000 to 4,000 or 5,000 people enrolled, at once. When we got, when AZT had enough evidence to support its efficacy, and then it was compared with cocktails of different drugs, whatever. And finally, we get to post-marketing surveillance, which in the era of COVID, eventually we'll get to, and we'll see more about the use of vaccines and or treatments in the real world, and see which perhaps subgroups of patients are either more protected or respond sooner, for particular drugs. Okay, I want to just touch upon biostatistics considerations. In brief, the statistical analysis depends upon how you define your outcomes, whether it's time to event, whether it's success or failure, cured or not cured. or whether it's a continuous variable such as blood pressure. Certainly the quality of the data, if there's missing information and there's a bias in terms of one treatment group, like in the AIDS clinical trial, with placebo, AZT versus placebo, those on placebo, some of whom decided to withdraw, before they even, took any drug, placebo. Key time points, the intention to treat principle has evolved from the AIDS epidemic. Intention to treat means analyze as allocated. So everybody who has been randomized, allocated to a different treatment group, will be in the analysis, be in the denominator. But then people realize that there are circumstances where just, either because of validation of entry criteria, people did not meet the eligibility criteria until they were already randomized, which happens, and it happened in the HIV. So they instituted a kind of a modified intention to treat principle, which would specify all those, a laundry list of criteria whereby we would be happy to exclude those patients from the denominator if they didn't receive any drug, and the reasons why they didn't receive drug. Okay, multiple outcomes, which we've spoken about, completeness of information, dropouts, study designs to derive an appropriate statistical sample size justification called a power analysis. You would set out basically, those outcomes that you want to determine whether there's a difference or not. And then the framework, which involves what chance do you want to make the wrong decision in terms of saying that the new treatment is better than the old one and being wrong. Or concluding that the new treatment isn't any better than standard of care or the old treatment. You could be wrong in making either of those decisions. So you would specify those, initially. Certainly sample size increases with multiple outcomes, multiple comparisons, and multiple time points that you're looking at. The investigators will work with the Data and Safety Monitoring Board, whose job it is to look at the accrual of patients and to see whether the trial is feasible, whether you're enrolling enough patients, given the time frame that you've specified. And they will work with you to determine how many or whether an interim analysis is planned, and that would impact on the number of patients you would need in your study. Certainly attrition, patients who were withdrawn. Some patients I've seen in recent clinical trials enroll and withdraw because they're too afraid of getting the placebo. So that's a reason for attrition. Finally, I want to just talk about in the last 20 years, there have been international biostatisticians who have gotten together to set up criteria for reporting of clinical trials. And the initial consort statement for reporting of trials involves parallel arm trials. And it basically goes through a laundry list. And then as time went on, those criteria have been modified or changed notably for other types of trials, non-inferiority or equivalence trials, which means that you basically want to prove the null hypothesis to say that the two treatments are not too different from one another. Pragmatic trials, having one region of the country, having their economy lifted, constraints lifted versus another region in the country. And And there are what's called N of 1 trials, which I could see being done in COVID, which would involve many different types of COVID tests to determine whether infection. These often are thought about with precision medicine, how to tailor a dose or a treatment to an individual patient. Basically, from those trials, you'll get serial measurements from a single patient. You can't extrapolate, but they're noteworthy for clinicians who are looking at the best treatment for individuals. Pilot and feasibility studies, which don't require such stringent requirements for power analysis, sample size. There are within person trials, pre and post, and extensions of randomized trials. Just to kind of summarize what's in these consort checklists, and these are things that you'll be doing, most of which when you write your protocol to be submitted to the IRB, but other things in terms of reporting. Now, unlike other manuscripts, publications, for a clinical trial, randomized clinical trial, you would have to have randomization in the title. You would want to register the clinical trial with clinicaltrials.gov. You'd want to specify the funding agency and indicate where one can find the original protocol and amendments to this study. You would list the protocol requirements in terms of inclusion, exclusion criteria. And then during the trial, you would want to document the changes in the process that you're making, either as a result of, say, adverse events or poor accrual. You might want to broaden the inclusion, exclusion criteria. And then even statistical methods. When you write an initial protocol, you're just I'm not guessing, an educated guess as to what sample sizes and statistical methods you would need. But until you really study the distributions and know how, get an idea of how patients, are randomized to different groups in terms of what characteristics that you may want to control for, and the distribution, say if 80% of the patients just end up in one group as opposed to 20% in the other, you would want to adjust your statistical methods to give the most optimal analysis and derive the best results. Okay, in terms of reporting, consort reporting, you would want to specify the numbers of patients who were screened, included, and withdrawn from the study during that process and the reasons why they're withdrawn. Certainly any adverse events, safety issues. They could be serious adverse events or just run-of-the-mill sniffles. And then in terms of estimates of study findings, you want to give the estimate of differences by group and also confidence intervals for these differences and point estimates. So in conclusion, I want to say that randomized clinical trials are the gold standard of study designs, and I appreciate your attention to this presentation and taking the time out of your busy days. And I will be happy to take questions in a few moments, or you can email me with questions if you so desire, or give me a call. And I'd be happy to discuss any trials that you are going to be thinking about in the future for epidemics or non-epidemics, or things that you're most important is that you're interested in pursuing. Thank you very much.